The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flight Bridge Ed in their entirety.
Hey, it's Evan, and welcome back to the Flight Bridge Ed podcast and the Fast Archives miniseries. We definitely have a treat for you in this episode with a talk given by William Heuser. Will is a clinical critical care pharmacist, course director, clinical professor of pharmacology, clinical toxicologist, and certified flight paramedic. He brings his passion and expertise to the forefront with his talk, Do Any of These Medications Work in Cardiac Arrest? Demystifying the Controversies. If you haven't ever been to a conference with Will, he's just as entertaining as he is informative. He leads us through the controversies and debates surrounding the use of certain medications during cardiac arrest. You know the ones I mean. The ones in the boxes that usually don't find their way onto the floor during a code. Or maybe they do. Prepare to have your assumptions challenged.
All right. So the rumors are true. Pharmacists try every medication we give out. So we'll talk a little bit about some of the things we give in cardiac arrest. And now I'd love to do an entire talk and crap on epi all day. I want to do some things that are against the grain. Maybe talk about things that calcium, bicarb. Is this things we should be doing? Trials recently just came out. So we'll talk about these cool and fun things. So I can't do this talk without talking about the COCA trial, right? COCA trial was a great trial. But once again, there's take-home points that me, although I'm a pharmacist by trade, I can tell you right now, I ride the helicopter every week. So I'm a critical care paramedic in the field doing exactly what you're doing. I just happen to wear a pharmacy toxicology hat as well. So let's talk about this study. So if I'm going to start with the top 5 reasons why I give calcium during a code, this may be things we don't think about. Right? We could go all into the troponin and tropomyosin, actin-myosin, and all those things. Let's boil it down to the fact that calcium is truly an inotrope. It's a vasopressor, right? Stabilizes those cardiac membranes, right? When anybody asks, oh, what does calcium do for hyperkalemia? We give the textbook answer of, oh, it stabilizes cardiac membranes. What does that mean? So small studies in the mid-80s. Maybe that's why we're doing it. But maybe it's because we're afraid of change. We don't have anything else better to do, especially when the family's looking at us and we have no other different color boxes to consider. All right, so this was the COCA trial. Great trial, similar to Paramedic 2 in terms of its study design, but looked at a couple different things and a couple very concerning things that you really got to think about. Should we be throwing patients the kitchen sink? It's not just, ooh, we have a cool new drug to use, let's give it a shot. We have to know when to give medications and specifically why we're giving these medications. So as you can see here, a lot of good things from the trial design, but probably what's concerning to me are those findings. We're given water or salt water and we're comparing it to calcium, and calcium shit the bed. That's really not something I want to be doing. Maybe I should think about other things before I give calcium. So who did they exclude? So this is always important when you design studies and look at how to evaluate them. Sure, we could look at confidence intervals, p-values, type 1, type 2 errors, but this is concerning, right? Because I want to know who actually should get calcium and why did they morally exclude these patients. Traumatic cardiac arrest, because we know calcium's role in coagulability. Pregnant, all the 3 Ps, right? Pregnant prisoners, pediatrics, always excluded in these trials. Suspected hyper-K, because once again, it'd be unethical to withhold a treatment that is definitive care for this disease state. And of course, suspected hypocalcemia. Now, I don't get bloods in the field, so I don't know how we would know that, but maybe suspected. Concerning. There's only 2 reasons why you stop clinical trials early. One, because the drug is doing really well and the other one isn't. And secondarily, the other one's causing a lot of harm compared to my other treatment arm? Which one do we think calcium fell into? The latter, right? Not good. But wait, what about other things? I promise, maybe it's the IV versus the IO. Maybe it's the rhythms because of resuscitation bias, and calcium is only given late in the cardiac arrest when shit is already hitting the fan. Can I look at that? Sure. They did a subgroup analysis. Nothing, right? All things that we would expect. Hey, this is something I want to do and I should be giving it for. So bottom line, let's make it easy. This was a negative trial. What stood out about this trial that I like? Well, I always look at how they match from a demographic standpoint. I don't know what far fantasy world this was, but great, 80% bystander CPR. That would be awesome. But why do I mention that? It's because that's a good study comparison to show that patients, even though they got the best treatment and calcium still did bad, doesn't make calcium look good. Time to epi was 17 minutes. Now, if you look at average time to administration of most medications in cardiac arrest, Paramedic 2, all these different trials, within 17 to 20 minutes is a pretty good thing to do from on scene, getting that first epi in, right? Once we got the Lucas on, we got access and so on. So that's pretty good. Another indication that calcium is probably not good. And then, of course, some people actually measured contraction fraction. So what do we do with this study? Well, giving calcium routinely, and let me make that clear, indiscriminately in cardiac arrest is harmful. Throwing them the kitchen sink is not the thing to do. Whenever I teach at the med school or I teach my paramedic class, I always tell them, know why you are giving medications. Always ask why. Is that the right patient? So if there's a clinical indication, yes, let it rip, right? Hyper-K, hypocalcemia, calcium channel blocker overdose, give it. Standard of care, it is a good treatment. Can we stir the pot even more? Can I give you better studies? Can I give you more recent trials? Well, I sure could. Right? This was a Thailand study. I don't really like including in-hospital cardiac arrest at these kind of conferences, but it's important to really look at and say, can I extrapolate this, or what we call external validity, to the pre-hospital setting? So what did they look at? And why I wanted to bring this up? They included traumatic cardiac arrest because we don't really know the best things to do in traumatic cardiac arrest. They looked at ROSC rate, which we know is not a patient-centered outcome. We saw that with many other trials. I can give epi to this stage and get a pulse. That does not mean anything for me, right? It's neurological outcomes and survival to hospital discharge is what I consider a good outcome, right? So they looked at a couple different things and they further stratified based on different values. If you look at here, right, they showed on the left side, your control was better. On the right-hand side, calcium was better. Not good, right? Calcium, another thorn in the side for calcium, especially in traumatic cardiac arrest where we thought, oh, calcium must be good. It helps with the coagulation cascade. That's probably good, but we know that evidence is important, right? Numbers don't lie. So what do we take away from this? So don't get excited over this result. It's a retrospective analysis. There's no benefit to calcium during emergency room resuscitation in this study. They, oddly enough, found that there was decreased chances of ROSC in hypocalcemic patients and potentially harm with calcium in traumatic cardiac arrest. But do I have the best trial design out there to find out if this is definitive, taking everything into consideration? Well, lucky for you, a couple months ago there were. So what did they do? So they included 10 studies. Now, if you put crap into studies, you're going to churn out the same crap. So you really actually have to determine what trials were part of the meta-analysis. We know that we want randomized controlled trials. We know that those have less of a chance for bias, all these different things. So they included 3 of those trials. Now you can see here, big time frame of difference. That brings in a lot of bias. Only one had low risk of bias. And what was that study? That was the COCA trial. So what did they look at? ROSC, or survival at 1 hour, and then probably more important is what I care about are those secondary outcomes. What are we taking away? ROSC at 1 hour, no benefit. Relative risk greater than 1. Survival to hospital discharge, no benefit. And what all patients and their families care about is why it's highlighted there. Their neurologic outcome, which they measured via 2 things, modified Rankin and a CPC score, not good. So that's another concern for calcium. So what are we taking here? So the problem is, as I mentioned, the results primarily reflect the COCA trial. So calcium has no benefit and can be harmful if given indiscriminately. Know when to give it, right? Give it in hyper-K, hypocalcemia, CCB overdose, or if you happen to be part of a clinical trial. So what's my take home for you? Stop giving it just because it's a different color box, right? We should know when to give these meds and why. And we should think about, hey, there's a good indication to give calcium. If not, don't be compelled to do it. What about this guy? Bicarb. I always get, does pressors change when you're acidotic? What's the pharmacology? You're the weirdo pharmacology paramedic guy. What's there? Now, there was all talk about biases, and I'm like, oh shit, somebody's gonna say something about my bias. My bias is we throw the kitchen sink whenever we think about bicarb, right? That's commonly what people do. Oh, they've been down for so long, right? How many times do we hear this? Well, they've been down for so long. We're denaturing proteins because we're so acidotic. Oh, and then catecholamines don't work as well when you're super acidotic. Is that the reason why we're giving it? So just a little bit of history of why we give bicarb in the setting of cardiac arrest. So its intent was, of course, to correct. If you give a weak base and then you give it to an acid, you should form a reaction, what we call a neutralization reaction. So, okay, fine. Then we got to the 80s. Well, maybe it was bad. Caused some degree of paradoxical intracellular acidosis. Hypernatremia, right? That's why we give it for a lot of your sodium channel blocker overdoses, because it's super hypernatremic. But what do the AHA guidelines tell us to do? Now, I work at a research lab where we're funded by the American Heart Association, so I know extensively why we do these things, but what is the reason why? It's because it's only indication specific, as we commonly have just talked about. TCA overdose, please give it, and give a lot, and give it fast, right? That's going to be a lifesaver for that patient. Hyper-K, same rationale. But does bicarb help for those patients that have prolonged downtime, right? That's the reason I'm giving it, right, Will? That's why I want to give it. Let's start with the first trial that actually showed potentially after 15 minutes of cardiac arrest, bicarb was better. So prospective trial, survival rate to the emergency department. And they stratified the downtime. Brief, moderate, prolonged. That's good. So maybe it's a time thing. And that's definitely something we care about in cardiac arrest literature, is this time resuscitation bias. And when is the proper time to give meds? Because we know that commonly the earlier you give meds and the earlier you do interventions, the better the patient fares. So what did this study do? There's a lot of methodological flaws here, unfortunately. All right, if you look at a lot of ways they kind of formulated the study, the outcome wasn't patient-centered. I don't care about ROSC. I care about neurologic outcome. There is no difference in survival in patients with prolonged arrest. Once again, resuscitation bias is a thing. If I'm only given bicarb late in the arrest, then that's you're putting bicarb behind an 8 ball. How is it going to show any benefit? What about if we give bicarb within 17 minutes of a trial, which they did in a study coming up? So this was a meta-analysis, right? A big subset of patients. Survival to hospital discharge. No difference between giving salt water and bicarb. What about obtaining ROSC? Okay, fine. I have to look at that. No difference. What do we care about? What do your patients care about? Good neurologic outcome. Bicarb is worse. What about sustained ROSC? Another good thing that I want to see. Worse. Retrospective study in 2022. They compared French database versus North American database. No association with neurologic outcomes in the French database. Worse in North America. What were we doing that was different here? Stop giving bicarb indiscriminately in cardiac arrest. But wait, maybe a study just came out that I actually had to amend my slides for so that you guys got the most cutting edge data behind what to do. Because I didn't like that, right? We all just commonly say, oh, don't give it unless there's an indication for it. But what if we looked at rhythms? Do shockable rhythms matter? What about PA and asystole? Right? Because commonly PA, we may think of hyper K, and that's why we give bicarb. If the patient's in VTAC and VFib, maybe it's early in the cardiac arrest, and they do better. Maybe that's why patients that have prolonged downtime have what we call a larger base deficit. And maybe that's why you're going to give bicarb. And earlier in cardiac arrest, acidosis is probably not the problem. Maybe that's when we shouldn't be giving bicarb. Maybe prolonged cardiac arrest, we should. So really hot off the press study. All right, what did they do? 2023. ESO database. Always very good, right? A lot of good things we can get from that. So what they do, they looked at almost 24,000 patients in their final analysis. And due to its retrospective nature, not the best study design, but they did a lot of propensity matching to account for your confounding variables. Now we see some things that are a little bit different than what we would expect. Here I am crapping on bicarb this whole time. Maybe I got to pump the brakes. Maybe rhythm matters, especially as you see those asterisks, which means it's clinically and statistically significant. Sorry. All right, so that's the thing that I want to look at. Those two rhythms, maybe there's something I could do now, right? Because what do we do in those rhythms normally? Give them crappy epi, God forbid I say that, and just keep on going with CPR, right? Maybe there's something now we can give and that actually works out well. Maybe this study gives us insight to what we can do. What about the limitations? Limited insight as to why the paramedics administered bicarb. Right? 1 in 4 paramedics in the study did administer bicarb despite the American Heart Association telling us that we should only give it for certain indications. So given its retrospective analysis, we have no idea why paramedics gave bicarb in certain situations. Now, they very well may have a good reasons, or they may, God forbid, give it indiscriminately. The risk of selection bias is there, right? It's not truly randomized, so really hard to say. Details regarding the little nuances that may change my study. For example, route of administration, timing of delivery, dosing frequency. They could not be accounted for. And that's because it's a retrospective trial. So could not provide information on functional status at time of hospital discharge, which we know is what we care about from a patient-centered outcome. So what's my take home from this? Patients who had asystole or PA had higher rates of survival to hospital discharge. No survival benefit in VFib or pulseless VTAC. Hypothesis generating only, right? We cannot imply causation on a retrospective analysis. So this is good. This paves the way and makes us think more about considering your underlying rhythm. So really overall importance of presenting rhythms. The best thing I have right now is, once again, stop giving it because you feel like it. Think about a rhythm. Maybe that's when we should consider giving bicarb. Last thing I'm going to talk about here real quick is how acidosis affects catecholamine response, right? Because I commonly get this question and people always want to know. Well, when you give bicarb, what are you giving the patient? A CO2 load, right? That's exactly what you're doing. So we have to think about, does the patient have sufficient minute ventilation to blow off the CO2? Because we know CO2 narcosis is a thing. That's why we intubate patients in the ER, right? Because their CO2 is so elevated. So is acidosis bad? Maybe. But if you really look at oxyhemoglobin curves and talk about right and left shifts, maybe when somebody goes from acidotic to alkalotic, it prevents oxygen from being offloaded to the tissues that are starving. Maybe it's not bad. What is it doing to our medications? So there's many studies looking at this. So I won't go crazy and tell you, hey, that's not something we should worry about. It is. It's proven literature behind it. So show us the data. Is there data behind it? Absolutely. Right? We know that there's many reasons why acidosis causes issues in terms of catecholamine response. Now, a lot of these trials were done in vitro or in animal studies. Very hard ethically to do these in humans. So there is a response, I will tell you, that is blunted when you have acidosis. So show us the data again about what is seen depending on your pH values. Now we're not getting A-sticks in the field like we just talked about. A lot of times don't have this luxury. Maybe a critical care transport. I have sometimes on the flight, I have access to this. But we see here, there's evidence showing you that lower pH definitely has a response in terms of your pressor requirements. So what are we taking away from this? Most conglomerate studies and looking at all this, the pH values that need to affect receptors, your adrenergic receptors, your pH has to be pretty low, right? So that's what we may think, why it correlates with that study that we just saw. Maybe because they're prolonged in those rhythms, maybe that's why bicarb is actually doing well. So they said take-home points, what are we looking at? So stop giving calcium because the box looks cool, right? I see it in the ER, I see it in the pre-hospital setting. Think about it. Same rationale. Stop giving bicarb for fun because they've been down for so long. Rather, look at the underlying rhythm. Maybe that's the rationale for it. And lastly, vasopressor hyporesponsiveness occurs at extremes of pH. I do want you to think about that, especially when you're working a cardiac arrest for a prolonged period of time. But usually, when they're in PA and asystole is when the drug works best. And that's that. Thanks, guys. Appreciate it.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.